So I thought this was appropriate to talk about pandemic flu and are we ready, because last year's season of influenza was pretty terrible, and so I'd like to discuss kind of why it was different than the years past and what we can do to prepare ourselves for pandemic flu, which is slightly different than our seasonal influenza. So I have no conflicts of interest to disclose. So as an outline, I want to talk a little bit about the basic epidemiology of flu. By the end of this talk, you'll feel like you know flu very intimately. We'll discuss history of pandemics and then go a little bit into preparedness and whether or not we're truly ready for a pandemic. So this is a great graph that just shows the life expectancy in the 20th century. And as you can see, the dotted line, our life expectancy has increased from somewhere between age 50 to up to age 80. From the year 1900 to 2000. If you look at the kind of the reverse of that, our age-adjusted death rate has gone down. But one thing happened in 1918 where those completely flip-flopped, and that was the 1918 influenza pandemic. So it was a pretty terrible time in America and worldwide that affected young, healthy adults. So in order to understand what happened there, let's discuss flu epidemiology. So globally, we see about 1 billion cases a year of influenza, with 3 to 5 billion cases of severe illness. This really equates to somewhere between 290,000 and 650,000 respiratory deaths annually. And that number is actually a new estimate compared to old numbers. Previously, we thought it was anywhere from 250,000 to 500,000. But the influenza-related respiratory deaths have now increased because they have recognized cardiovascular deaths after having influenza. In the United States, we see about 25 to 50 million cases annually, with 365 hospitalizations and somewhere around 50,000 deaths. As you can see here, this is the CDC flu view. This is something that I stare at like every single year, trying to figure out what's going on and whether or not the hospital should be concerned about seeing more cases. So the yellow bars are going to be your influenza A, and the blue bars are influenza B. And on the bottom, on the x-axis, is all the weeks. And so this is a typical curve that you'll see in influenza, so based on the 2017-2018 year. And so you can see it kind of trails out somewhere around April. If you look at other seasons, however, the 2017-18 flu season was extremely different than some of these other seasons. So the dark blue line is going to be your 2016-2017 year, and then that light blue is the one that's pretty high. And you can see that the 2009 swine flu pandemic is almost similar in terms of numbers, and this was visits for influenza-like illness, which is something that the flu monitors. At the height of influenza last year, influenza accounted for 11% of all deaths. So it was a pretty severe season. If you look at another way to look at this is the pneumonia and influenza mortality data, and you can see every year from 2013 onward, we have these typical spikes. And we pass that epidemic threshold. And so that's pretty much the percent of all deaths due to pneumonia and influenza. And last year it was a pretty large spike and a wide spike, so it stayed long in our season. So what is unique about influenza? Well, it's a segmented genome. It's a negative sense RNA. And this segmented genome differentiates it from other viruses and allows for what we'll talk about further, something called antigenic shift and antigenic drift. There are two proteins on the outside surface, and so one is hemagglutinin, which is HA, and then neuraminidase. And so hemagglutinin is a glycoprotein that binds to your respiratory epithelial cells, and that allows for the initiation of infection. And then the neuraminidase then cleaves and prevents the virus from clumping together, and then allows the mature virus to release. So they kind of work in conjunction with one another to really to cause infection in people. So what we know is HA and NA can mutate over time, and these H's and N's make up your H1N1, your H3N2, so that's where we get those special names. And so on the right-hand side, you can see the A/Fujian 411-2002. So that's the virus type, the origin, the strain number, the year of isolation, and then the subtype. That's how the CDC and WHO classifies all these different viruses. So antigenic drift occurs when you have these small point mutations in the RNA gene segments, and this typically occurs as a virus spreads throughout a susceptible population. So that's what we typically see in an epidemic, where you got vaccinated, but for some reason the virus mutated a little bit so that the vaccine doesn't work as well. Initially, that's what they thought happened in 2017, 2018, but it's actually the virus that was circulating was very much similar to the virus that was used for making the influenza vaccine. And so what they think happened was when they made the egg-based manufacturing, it caused these small amino acid changes in the vaccine that might have contributed to differences in circulating viruses. But I will say what also probably propagated this was the fact that only 37% of people received an influenza vaccine last year. So those low vaccine rates, along with maybe less effective vaccine, made this just the perfect epidemic to occur. Now, what we're talking about today is something called epidemic shift, antigenic shift, and that is where pandemics occur. So antigenic shift is just a major change in one or more of the surface antigens, and this is really due to a change in subtype because of genetic recombination. So remember, we said this is a segmented genome, and really this is zoonosis that plays a role in this shift. So what you can see on the right-hand side is a picture of what happened in the 2009 pandemic. So you can see you have the North American avian flu, and then you have the human, and then you have swine. And so all three of those somehow combined into one pig, and then three pigs then combined into another one, and then somehow it spit out swine flu. I'm not going to go through all the crazy biology of that, but it was a really triple reassortment of multiple swine, avian, and human influenza viruses. And so because of that, no one had been exposed to this before, so it rapidly spread. It went unrecognized really because it occurred in the springtime rather than in our typical fall time. There were 25,000 deaths worldwide, particularly in young. And then by September, a vaccine was developed, approved, and manufactured, and then was available for distribution. And I'll say that the swine flu is in every single influenza vaccine from this point forward because it was such a terrible pandemic that occurred. So what makes a pandemic influenza virus special? Well, you have to isolate it from humans of a novel subtype where the general population has little or no immunity. It has the ability of the virus to replicate and cause disease, which makes sense. And then it has to efficiently spread from person to person. So if you look at these different pandemics, so here's the 1918 Spanish influenza, and we'll talk a little bit more about this. So you have bird to human transmission, and really most of this was just bird. Almost all of the 8 genetic segments were found to be bird. And then here in the 1957 Asian influenza was an H2N2. So you have your avian and your human, they reassorted, and then you can see the green human mixed with the avian viruses. Your 1968 Hong Kong influenza was H3N2. And that was your avian that was mixed with that mix of the H2N2 that we saw before. And so they added those avian parts. And then this was actually created before the 2009 swine flu pandemic, but we talked about that triple reassortment. So here are some hemagglutinins that we've seen in the 20th century. And so since 1918, we've seen that H1, and then followed by H2, and then H3. And so only H1, 2, and 3 have caused sustained outbreaks in humans. We've seen some of these smaller H5, 7, 9. Last year there was a discussion about the H7 virus that was an avian virus, and that was floating around. But it really hasn't been sustained nearly as much as H1 and H2 and H3. So since this is the centennial of the 1918 influenza pandemic, I thought we could talk a little bit about what happened. So it was in the midst of World War I. It lasted for about 15 months. And it was thought that this was really propagated through troop movement as well as crowding. This was at the dawn of modern medicine, but when this was introduced, it was thought that influenza was caused by miasma, which is vapors in the air. So it's really not as understood that it was a virus that was causing these symptoms. It had a high case fatality ratio, in particular pneumonia, and high mortality in young adults, which is something that we don't typically see. And there were the only interventions that they could do. They didn't have vaccine. They didn't have medications. So it was really social distancing, school and work closures to try and prevent the spread of this infection. So I thought I would show a few pictures. So this is that troop crowding that we were talking about. This is probably 100,000 troops on a single boat going over to Europe. And so you could see, because of how close everybody was, if one person was sick, it easily spread from person to person. This is a picture that was taken, I believe, at Fort Bragg, and you can see all the young, healthy soldiers that are affected by influenza. And the only kind of protection that these healthcare workers had were these simple masks to try and prevent themselves from getting it. The pandemic was so bad that it actually knocked out a huge workforce of nurses. And so this was an ad that was placed in Chicago, and it says earn $15 to $25 a week, and you can learn how to be a nurse at home with 32 lesson pages with illustrations. So some of the nurses in the room are laughing, because if you could learn everything you had to learn about nursing in 32 pages, that's pretty ridiculous. You can see here, these are some of the masks that they were continually creating to protect themselves and to protect the spread. And this became the poster picture of the pandemic. You know, even your healthy postman was wearing a mask to try and prevent the spread as he was delivering the mail. So what did we learn from this 1918 pandemic? Well, the H1N1 virus has been synthesized, it's been evaluated, and it's really unclear what properties made it so devastating. We had no vaccines, we had no antibiotics for secondary infections, we had no influenza medications. And so really the only thing that we had were these non-pharmaceutical interventions that were key to controlling an epidemic: isolation, quarantine, hand hygiene, use of disinfectants, and limitations in public gatherings. That's probably something that you've heard typically in the flu season, because that's something that we continue to tell everyone. Wash your hands, don't come to work if you're sick, simple things like that to try and protect ourselves and others from infection. So I thought it'd be important to kind of look at the differences between these different pandemic years. And so the biggest one, of course, is the 1918 Spanish flu pandemic. It was H1N1, and it's thought to have occurred because of that avian influenza. The estimated reproductive number was 1.2 to 3.0. And so if you haven't heard of a reproductive number, that's how many people it takes to infect that typically are infected by you. So for instance, in measles, your reproductive number is 14. It's highly contagious. And for Ebola, it's only 2. For HIV, it's 2. So this was around 1.2 to 3. The estimated case fatality doesn't seem that high, right? 2 to 3%. However, because of so many people that were affected and so many young adults, the estimated attributable mortality was ridiculously high. 20 to 50 million people. In the US, 675,000 people died, and mainly it was young adults. In 1957, we had the Asian flu, and that was H2N2. The estimated reproductive number was 1.5, and so the case fatality was much lower. It was less than 0.2%. It still had a pretty high mortality, 1 to 4 million. In the US, there were 70,000 people that were affected, and it affected all age groups. In 1968, you had the Hong Kong flu, which was H3N2. Similar reproductive number, similar case fatality to 1957, and it affected similar numbers, 1 to 4 million. And in the US, it's about 34,000. And then finally, there was the 2009 swine flu, which had a 1.1 to 1.8 reproductive number. Case fatality is about the same. And you can see the attributable mortality, though, was much, much lower. It's 100,000 to 400,000. I'd like to think that this is because we were understanding pandemics better, understanding how to control this better. But it's still, those are devastating numbers. In the US, there were 25,000 deaths, in addition to the seasonal influenza that they were already seeing. And it affected a high amount of children and young adults. So if you've ever seen a child affected by influenza and being in the hospital, it's pretty hard to see that major group being affected. This is a great infographic from the CDC, and it just kind of talks about some of these influenza milestones that we've seen. So in 1917, U.S. entered World War I, life expectancy was 54 years for women and 48 years for men. And then in 1918, that life expectancy dropped by 12 years because of the influenza pandemic. In 1919, there was a third wave of pandemic flu activity. As that subsided, it continued to circulate seasonally. For 38 years, we've seen it seasonally circulate since that time. It wasn't even until 1930 that we first noticed that influenza was actually a virus. So before that time, we just didn't have the capability of totally understanding what was going on. By 1957, we had that second pandemic that replaced the 1918 H1N1. In 1960, that was the first annual flu vaccination that was recommended. By 1968, we had that third pandemic. And then in 2005, that was when they actually took the genome of the 1918 pandemic flu, and it was fully sequenced to try and understand what made it so unique. And then in 2009, we saw this H1N1 virus that was really distantly related to 1918 pandemic that triggered the swine flu pandemic. So I think this is funny because this is the actual Lancet article that found that this was a virus, that influenza was a virus. They took the garglings of an influenza patient and infected ferrets, and that's how they found out it was a virus. So just, some fun tidbits of history. There you go. So are we ready for a pandemic influenza? Well, if you ask Time Magazine, we are not. Based on all of these pictures, we have death threats, why you'll be wearing masks again, we're not ready for a pandemic, nightmare scenario. This is the stuff that's propagated in the media about pandemic flu. And so the question is, are we truly ready for the next pandemic? Well, if a 1918 pandemic occurred today, we would have disruption of transportation and supply chains. Just think, we order things from Amazon all the time, but if your Amazon person is knocked out, like that whole distribution area is knocked out from pandemic flu, you won't get your normal boxes of, I always get toiletries, from Amazon. You could have potential disruption of healthcare services. You can have potential high economic costs. So just to remind you, SARS was a coronavirus, and that was a pandemic. And that cost $30 billion in 4 months. So it's estimated that if we had something like 1918 flu pandemic, it would be anywhere from $181 to $570 billion for a moderate to severe influenza pandemic. This is a framework that was assessing the effects of influenza epidemics and pandemics. So trying to figure out, these are modeling to figure out what would it cost if we had different transmissibility. And so in the first column, you can see pandemic severity, moderate, severe to very severe. And even with a 20% transmissibility in the moderate group, that would affect 64 million people, 160,000 of which would have ICU care, and 48,000 deaths. If you went down the very severe category with 20% transmissibility, those numbers skyrocket. So you would have just ridiculously high numbers and deaths. So the 48,000 jumps to 1.3 million people that could potentially die if we ever had such a severe pandemic again. So in 2017, the CDC updated their pandemic influenza plan, and it included these 7 domains. So the first one is surveillance, epidemiology, and laboratory activities. The second is community mitigation measures. The third is medical countermeasures such as diagnostic devices, vaccines, therapeutics, respiratory devices. Number 4 is healthcare system preparedness and response activities. Number 5 is communication and public outreach. Number 6 is scientific infrastructure and preparedness. And then number 7 is domestic and international response policy. So we'll go through some of these to discuss where are some of the areas and gaps in some of these plans. So in terms of surveillance readiness, we have some pretty good strengths here. So we have domestic surveillance. We have about 8 systems, which cost about $100,000 a year to maintain. And globally, we have global surveillance through the WHO participating laboratories. We are sequencing all new flu viruses, and they're sent to the CDC, and there's a lot of sharing with access to the public database. That's how I can go into FluView and look at the data and download the data And you as public health students can get that data as well and kind of ask research questions from that standpoint. The gaps, there are data deserts. And so that, in Africa, in the southern hemisphere, there's a large amount of missing data of what happens when influenza spreads through there. And there's really inadequate surveillance in birds and swine. So remember, pandemics are caused by zoonoses. So if you could monitor swine and birds and see what is circulating in them, maybe you could accurately predict what could occur going forward. So this is a pandemic intervals framework, and it really describes the progression of an influenza pandemic, and it utilizes 6 different intervals. So you have your pre-pandemic intervals and then your pandemic intervals. So if there's concern about a new virus, the CDC will initially investigate and recognize what's going on, and then they'll start initiating this pathway, including creating a new vaccine for that virus. They'll ramp up communication and those sorts of things and utilize this pandemic plan to really hopefully cut down the time that you're exposed to this pandemic. This is a novel influenza risk assessment tool. So it takes these available information about these different viruses that are circulating from animal studies, and on the x-axis you can see the potential to cause an influenza pandemic, and then on the y-axis is the one to cause illness. So if one of these became a pandemic, how severe would it be? And you can see right now that the one that's winning is H7N9 from China in 2017. And so what this risk assessment can do, it can inform response through enhanced surveillance of that H7N9. So maybe they would want to target some money to focus on the avian influenza outbreak. You could evaluate antiviral resistance. You can develop vaccine viruses and be prepared to go ahead and produce more of those. And then manufacture a stockpile, as well as implement control measures in small areas so you could really kind of focus your efforts to protect people around that area. And then finally, the CDC has this pandemic severity assessment framework. And so what this does, it tells you how severe a season is and how transmissible it is. So our seasonal range is going to be kind of in that blue-green. And you can tell right now that the 2017-18 seasonal flu season was outside of our seasonal range. There was something that was extraordinarily different about this season compared to others. Over here is going to be on the most severe and highest transmissible one was this 1918 pandemic. So we continue to monitor these to make sure that there's not something that's reaching this very high severity. So this is the WHO Global Influenza Surveillance and Response System. This is the oldest network, which began in 1952. And it has 6 collaborating centers. It's in 113 countries, but you can see here that there's just a huge lack of information kind of in these in Africa. This is where that data desert is. So moving on to diagnostic readiness. So we have global distribution of free testing materials. We have greatly improved commercial assays. So if you've ever been tested for flu before, the nasal flu swab is really all dependent on how far back you can cram that nasal swab into your nose. You actually want to be crying when you're done, and that gives you a higher yield. But we have better tests now. We have you really do want to be crying. So we have better tests now, such as PCR, that's faster and it's more accurate. And I think we're getting to a point where we can get better data to identify these things quicker. Unfortunately, there is limited flu testing and just poor lab capacity in a lot of developing nations. And it's really difficult and slow to confirm a novel influenza because it has to go through a lot of sequencing to determine if it's new or if it's something that we've seen before. So since 2010, all of our U.S. public health laboratories allow for real-time reporting of about 80,000 tests per year, so these PCR tests and these antigen tests. And so this, if you go to FluView, this is at the week ending in October 20th in Alabama alone. You can see that 2 weeks ago we were at 2% of positive specimens. Now we're going up to 6 or 7%. So you can see we're starting to ramp up all more reason to get your flu shot right now. I'm just going to keep plugging that in to protect you. And what we really need is new technology for influenza diagnosis. If there is a way to protect other people, so say you feel like you have the flu, you don't necessarily want to go into the doctor's office and spread your flu particles all over there. So instead, what if we could get new technology that will allow for us to diagnose this? And this is a company that has a connected diagnostic platform that is for use at home and by healthcare professionals. And so what this is you get your own swab, it's sent to you, and you put it in, and then your iPad will tell you, or your phone, whether or not you have influenza A or B. And if we could really scale this up, you can use geospatial networking to determine if this is, you know, an area that's a hot pocket for influenza H1N1 or H3N2. And I really hope that this is where we're going, because if we can get fast, rapid diagnostics, then we can prepare quicker. All right, so let's talk a little bit about vaccines. So are we ready for a next pandemic flu? Well, so we have new vaccine technologies that we're working on and are available. We have improved virologic forecasting. We have more manufacturing capacity. But really, it just takes so long for a vaccine to become available during a pandemic response. And we need more current vaccines to work for a truly universal vaccine. So let's talk about how a vaccine is made. And so what you can see here, this is in summer, fall, and early winter. In the southern hemisphere, we start surveilling and seeing what's floating around in there. You get the epidemiologic behavior, and then these variants are sequenced, and then it's determined which ones should go into the influenza vaccine. So what occurs in Australia is typically what goes into our influenza vaccine here. So around January or February, these specific strains are put into these eggs. And so the viruses are manipulated, and then they're grown in eggs. And so this egg-based vaccine technology. This takes 20 weeks just to do this right here, 20 weeks to grow it up in eggs. And then it's spun down, and then it's created into a vaccine. Our current vaccines have either 3 or 4 strains in there. So we typically always have an H3N2, which is what we saw around last year. We have that H1N1, and we always have one B virus that's around. And you can see that there's a lot of mortality and morbidity because of neutralizing antibodies. So we really want to be able to demonstrate immunity. And so a lot of this has to determine with what you've probably heard before as vaccine effectiveness. So for instance, if you're good at matching it, like in the 2004-05 season, it was a terrible match. It was 5% match to what was going around. And so that's only 10% effective. In the 2006-07 season, it was 90% match, which is pretty good, but it was still only 52% effective. And this probably has a lot to do with vaccine uptake. So if only 45% of the population are getting vaccines, even with a really good match, it's not going to protect you 100%. So you can see this is the seasonal flu vaccine effectiveness over the years. So some years have been pretty abysmal. And the vaccine effectiveness for 2017-18 was the same as 2016-17, so about 40% effective. But it was still just an abysmal year in terms of how many flu cases we saw and flu deaths. This is a great talk that I went to at ID Week that just discussed if you could do incremental improvements to the existing vaccines, that can improve effectiveness. So the red line is your vaccine effectiveness, so as you go up, it improves. But really, the combination of vaccine effectiveness and vaccine coverage together is that purple line. So you really need both in order to protect your loved ones from from influenza. So this data shows that doses have increased from 87% to 490 million for influenza vaccine from 2004 to 2013. We've done a really great job in trying to distribute influenza vaccines. But what you can see here is on this circle, 47% of the world's population has access to only 4% of the total influenza vaccines. And that's mainly because most of these are distributed to the Western Hemisphere, which is what these are. So this is the Americas, Europe, but these are going to be Africa and some of those other Middle Eastern countries. And so we really have to work on improving vaccine coverage. So if we had a pandemic and we wanted to distribute that pandemic influenza vaccine, you would have to figure out a way to give it to people in those areas. So what could be our vaccine response in a pandemic? I'm going to talk about 3 different ways. So option A is your conventional approach, option B is your alternative approach, and then option C is the game changer. So the conventional approach is really to just prepare a library of candidate vaccine viruses. So we just have this library that's there, and then when we see that this one is actually causing a pandemic, then we'll take it and we'll determine what antibody and then prepare a new vaccine. But remember what I said, it took 20 weeks just to prepare that for the 2009 pandemic. So you really have a huge diversity as well. So you would have to have just a huge, vast library of all these different viruses and be prepared to take one out and hopefully that it will work the first time that you make these vaccines. Remember the growth in fertilized egg. In 2009 pandemic, it took about 26 weeks. It left large numbers of Americans vulnerable to severe illness. And really the goals from the CDC for the next 10 years is to develop and clear diagnostic tests that can identify these subtypes in 20 minutes, so then you can diversify your vaccine production process. There's a great website that's called nextflu.org, and so if you go there, you can kind of test these different viruses to see which one could potentially cause a pandemic based on where they're located. And you can see once again the diversity of all these circulating viruses that we see. All right, so option B, this is to elicit broadly cross-reactive subtype-specific immunity. So really you want to enhance your cross-reactivity to the antibody response. So could it be a whole virus vaccine or combination vaccine platforms, select difference in vaccines, something where you're not having to get a vaccine every year because of all the different circulating flu. Unfortunately, I think this is a little bit harder to do at this point in time. Something that would be interesting, though, is option C, which is a universal influenza vaccine. So instead of focusing on those little H's and N's, what if you could do it on the stem of the H instead of the thing that's most common for all influenza vaccines? So they've been working on identifying targets, but there are some challenges because of just the wide range of these influenza viruses. So hopefully in the coming years, we'll just have to get one influenza virus vaccine rather than all these different ones that go in there every single year. So this is in discussion of some of the issues that come up with pandemic preparedness. There's therapeutic and clinical readiness. So we have a lot of antivirals that are stockpiled for about 60 million courses. And we partner with pharmacies for improved distribution. And we're working on new drugs and therapies. But in the epidemic last year, there was some of the local pharmacies ran out of their stockpile and had to call some of the distribution places to bring it in. So that delays your therapy by a day, which then that means one more day of illness, or it could potentially mean going to the hospital. In addition to this, there's need for better therapeutics, need for reusable respiratory protective devices. So what this shows here is the number of respiratory protective devices in billions, and this is the need, but currently we are down here. So if we ever had a 1918-like pandemic, we would never have enough respiratory protective devices to protect ourselves and others. And so the market supply is quite low. And then we want to augment our clinical support capacity. So what about new drugs? So for the first time in 20 years, Xofluza was just FDA approved. That occurred last week. It's the first influenza drug in nearly 20 years. And it's baloxavir or Xofluza. And what that is a single dose of an antiviral medication. So rather than 5 days of therapy, you just take one pill. And it alleviates influenza symptoms. It was actually superior in reducing your viral load 1 day after initiation in comparison to Tamiflu, which is the only drug that we've typically seen around. So if you could think about giving someone one pill, you could probably have a better response to a pandemic than you would If you had to give a 5-day supply or something like that, it's much easier just to dole out one pill. You come into your pharmacy, get your pill, you can take your pill, and then you're done. So I think this has a lot of excitement kind of generated behind it. So in terms of preparedness, planning, and response, we have a lot of strengths internationally. There are a lot of health regulations for greater awareness and response. We have the WHO Pandemic Influenza Preparedness Framework, which really supports improving surveillance during an influenza pandemic. And we have greater government awareness of the impact of these infectious disease hazards. In Jefferson County alone, we have a pandemic coalition that meets and does tabletop exercises. So a lot of the hospitals around Jefferson County have prepared themselves for what to do in a pandemic and have worked with other hospitals. So UAB has worked with Princeton and has worked with St. Vincent's in terms of sharing some of the resources available and kind of notifying one another. Unfortunately, most GAPs don't have a robust pandemic plan, and only 1/3 of our countries are really ready for a pandemic. So in conclusion, seasonal influenza causes a significant burden each year, but the 1918 pandemic flu was really just exceptionally severe, and people are still trying to understand what made it as bad as it did. If we had a similar pandemic right now, it would cause severe illness, death, and significant cost. If we could detect these emerging novel influenza viruses in a quick and timely manner, I think we would be more prepared to be able to, for a pandemic flu. Our efforts to improve pandemic readiness are underway, but are we really ready for another pandemic? I think we are a lot better than we were even in 2009, but we're still not where we need to be. And ultimately, an effective pandemic response requires robust routine infection prevention and control. So just as a reminder, once again, the thing that stopped the 1918 pandemic was hand hygiene and quarantine and surveillance. And that's a lot of the stuff that we do in the hospital. We have a whole bunch of infection preventionists in the room today, and they work hard to continuing to develop these guidelines in the hospital. And that's what every hospital needs, is a really strong infection prevention and control group.